I'm Professor Andrew Coats. I'm Director of the Monash-Warwick Alliance and Academic Vice President of University in Australia and University in the UK. I'm a member of the Heart Failure Association of the European Society of Cardiology and an expert specialist in chronic heart failure and its treatment. I've come to this meeting today to talk about novel developments in the treatment of chronic heart failure and unanswered questions. In my talk today, I covered the development of heart failure treatments, what's changed since the last European guidelines, which were in 2012, while we await the new guidelines coming out at the end of this month. I highlighted changes in drugs treatment, particularly two new trials that have come out, the PARADIGM-HF and the Atmosphere study, and in addition, what's on the horizon for new devices. So the two most important trials that have come out is Atmosphere, which is the renin inhibitor, which showed no advantage of using a renin inhibitor either as an alternative to an ACE inhibitor or in addition. So I think it's really shown that renin inhibition doesn't seem to add a lot in the treatment of chronic heart failure. In contrast, PARADIGM-HF looked at the combination of valsartan with a neutral endopeptidase inhibitor in the drug that was called LCZ696, now called sacubitril/valsartan, that showed a substantial superiority over enalapril, the ACE inhibitor. So the question now is, how do we implement those changes in practice? How many of the patients that see a heart failure cardiologist or a general physician would be suitable for a swap over to the new drug? PARADIGM-HF was a very important trial. It showed that sacubitril/valsartan was superior to enalapril. The issue is, how widely can we apply that in practice? Because the trial was the first of its kind with that particular combination pill agent, and as a result, we only have that trial to go by. The question is, the patients in that trial were very highly selected. They had to have established heart failure, they had to have elevated natriuretic peptides, but they had to have already tolerated relatively high doses of ACE inhibitor and the trial medication. So when we have patients who aren't on high-dose ACE inhibition or haven't tolerated that, we really don't know whether the drug would be as superior in that patient population. So in my own belief, I think we need another trial to answer the question in a broader patient population.